All right, good. We are back. This is Senate Health and Welfare Committee meeting, and we are continuing our work today with S69, Suicide Prevention Lifeline Call Centers and Suicide Prevention Programs Commission. And so we have two folks here to testify, and then we've got friends who can answer questions. Katie McClin, Katie, you are here with a possible amendment that
joined the meeting.
Okay, Katie, you are here with a possible amendment that we will look at, and I'm thinking might be best just to get some testimony from folks first, and then go through the proposed amendment. Does that work for you?
Yes, absolutely.
Okay. All right, terrific. All right, so let's turn to Allison Crump, who is the Deputy Commissioner for the Department of Mental Health. Allison, thank you so much for being here and also for being patient with us this morning. We've had a long day.
Completely understood. For the record, Allison Crump, I'm the Deputy Commissioner for the Department of Mental Health. We do have a couple slides just to show you some of the things I'm going to talk about. Erin, is that something you might be able to put up?
Okay. You can send those to us. You just have them there on your. Are we refreshed? Okay, we do have them. Terrific. All right.
Great. So again, thank you for having us here. I know many of you have already indicated your interest and a sense of urgency around suicide prevention. So we really appreciate the time. I see my goal here as letting you know what exists in the governor's recommend in terms of what the current budget is intended to pay for. But I did want to start out, I'm not going to spend too much time trying to sell this committee on why suicide prevention is necessary and that it's a major problem for Vermont. But if you could go to the next slide, Nicole, I did want to highlight that we have had a major suicide prevention issue in Vermont for over a decade. Our rates of suicide prevention have increased year over year and increased more than the national average. But particularly if you look at this chart for 2021, we lost 142 Vermonters to suicide in 2021. That's astounding in comparison to previous years. We've always said that we believe the mental health pandemic will come after the healthcare pandemic, and we expect that there's going to be a major ripple effect for mental health needs post-pandemic. And we are seeing this, and some of the theories are this is about increased isolation, as well as economic stressors and just general, losing your sense of optimism in a world that's become very uncertain. So I wanted to make sure this committee is aware that although this hasn't been a problem, this is very much showing to be a problem that's completely skyrocketed in the past year.
And thank you, Allison. Could I just ask how these numbers fit with the 181 overdoses?
Yes, so there is, when it comes to the review of at autopsy, it's I'm not going to sell it as if it's an absolute clean, cut line. Sometimes there are complexities that make it difficult to tell if something was an intentional overdose versus an unintentional overdose, but there's no overlap in the numbers. It's decided either one or the other. And so we certainly, for this, that usually involves either some kind of social autopsy that would tell us that there was an intentional overdose. So we suspect this may be underrepresenting at times. The other piece I wanted to highlight for the committee, if you can go to the next slide, Nicole, is that there's a lot of players in suicide prevention. So even though the next pieces we're going to show are about a Department of Mental Health budget and Department of Mental Health initiatives, we are coordinating very regularly with the players on this list as well as others. But I did want to highlight these because I know the committee probably hears about this issue from other departments and agencies, as they should. So we work very closely with VDH, the Department of Health, to do some promotion and public health approaches for this. There's a Center for Health and Learning who's been doing suicide prevention work for over a decade. They're basically the glue that I think brings a lot of people together on this work. And the designated agencies are out there doing the suicide prevention work and treatment. And then we have other partners, including the Blueprint, Veterans Affairs, as well as a coalition. Like if you were to think of roots in Vermont that go down to making sure that you're getting feedback from everyone, the Suicide Prevention Coalition has a very large membership from primary care, people with lived experience, parents, emergency department providers. And so we do have this great infrastructure. And I just wanted to make sure the committee is aware that we are talking. We meet sometimes weekly, some of these groups. And so they're very much involved in the work. I'm going to move you to the next slide, which is just what is in the governor's recommend for suicide prevention and what is it funding. So the funding is for 3 pieces. It's for expanding zero suicide to all 10 designated agencies and 2 special services agencies. Right now, we have funding that has supported 7 to come on board at varying degrees of implementation. So 3 of them have been at it a long time and are further along. 4 of them have kind of gotten started. And then the other 3 of the DAs have not been able to come on board at this time. So this would move us further along. A second piece is statewide leadership and coordination. That's the position that you'll see. We're looking for 1 FTE to devote time and leadership to ensure coordination for this issue. The third piece is expanding programs that support older Vermonters. So we've been working with VDH. They have the data gurus and the epidemiologists to look at what do we know about the people we're losing to suicide in Vermont. And for the past few years, we've seen older Vermonters dying at a higher rate, particularly compared to the nation. So this was a targeted initiative to try to get at that, particularly with the pandemic, where there's been further isolation for older Vermonters. So this would expand a program that goes out and provides mental health supports to older Vermonters in their homes. I'm going to show you the budget on the next slide. This is what that looks like. The top pieces are for what was in S69. That's the position. It's and then it is also the contract to do elder care outreach. Zero suicide is beneath that. That was the ask to expand what we're already doing. And then what's below that is a 988 line item. And so we move forward with that, kind of treating it a bit separately. And so that funding was put forward in the BAA. So those are the pieces that kind of make up the suicide prevention effort from DMH's lens and what's been put forward in the governor's recommend. And I do have just a brief overview. Yeah.
Just a brief interruption here. So this was in the governor's budget originally. And can you tell us how much, if any, of this currently exists in the bill as it came over from the House?
Yes, so it's my understanding that this is in the bill that came over from the House. So the 440 and then the 260, the numbers as is.
Okay, thank you.
Yep. And so just to briefly give you a clue of what this means when we say zero suicide or any of these topics, if you could go to the next slide, Nicole. I just wanted to highlight kind of where we are today, what the budget is recommending and where that would take us. So the budget as it stood over the past few years was $190,000. I believe we've done a lot with $190,000, and a lot of credit goes to the DAs because they've done a lot of the work. And then the Center for Health and Learning has been their sort of major support. So this would take those kind of steps and really elevate them and take it further to all of the designated agencies. And zero suicide, just so you know, I think the term can sometimes seem vague. It is a public health approach to suicide prevention. So it just has a lot of ingredients. So far, the Department of Mental Health has kind of needed to focus based on resources on training mental health staff. So we've given this funding to the Center for Health and Learning. They've helped make sure that if there's someone who's suicidal in the community and they get referred to the designated agencies, that there are staff there who know how to treat it effectively and with best practices. That's been the focus. We would like to get to a place where we have more ingredients than just that one, because when we look at the data, most people dying by suicide in Vermont are not making it to the designated agencies' doors, and they're not served by the designated agencies. And so how do we figure out how to A, get them there, or B, make sure that there's other providers in the system and community members and everyone who can help with this issue? So that's what we're trying to elevate with this next phase. And it has been effective in other states. There's really well articulated models. And I also just want to note that we're not just relying on other states' outcomes. VCHIP has been an incredible partner in this. And Dr. Tom Delaney has already testified in the past and would be available again to show evaluations of zero suicide in Vermont. That's the zero suicide piece. I'm happy to answer more questions about that. I know you have limited time. So I'll move forward unless you shout out to stop me, Senator Lyons.
All right, I'll keep going. You've got
Okay.
slides, it's great.
All right, we're almost finished, but just to highlight elder care outreach, it's an existing program. We think it's the model where you meet people where they are at that can be the most effective, and people really like it. And so this is something that is a partnership with DMH and Dale, and this would be able to expand the program. So it's as all the things I've said prior, so I won't revisit them, but it's absolutely in need, and we have an aging population in Vermont. The next piece is the position. And so a recent suicide prevention resource center survey showed that 90% of states have a designated position for suicide prevention. I'll tell you, if you go to that website, the SPRC website, you'll see my name listed as our state suicide prevention coordinator. That's because you have to have one. And so I've been wearing that hat since I came to the department, mostly out of passion and interest in my background as a crisis clinician. But it was not my job. I was a senior policy advisor. I've had 3 different roles at the state, but I've worn the hat the whole way through. I'm now the deputy commissioner, and attending to this has gotten harder and harder and harder, especially as it's grown, which is great. We have a lot more going on for suicide prevention, which is a really good thing. But we're one of the 10% that doesn't have a position, which, given the data that we've talked about, we are not doing well for suicide prevention when you stack up nationally. And it's the second leading cause of death for Vermonters aged 15 to 34. So we're feeling like A, it's about having it be a priority, but B, there's a lot of interest right now in suicide prevention and some opportunities for funding, as well as lots of partners who are interested. So having a person we think would really make the work much more effective. So that's the position as it stands now. Those are the 3 pieces that were put forward in the budget and the governors recommend as part of like the Zero Suicide Initiative. This last piece is 988. This one's a little bit more complicated. The budget that's put forward for 988 right now, which is $440,000, is to cover sustaining the lifeline as it is now. So if you're not familiar, there's a national suicide prevention hotline. It's the 1-800-273-TALK. We're transitioning to a 3-digit number, everybody, the whole nation, by July of this year. The hope is that it'll become that one number you can call. Right now we have a great crisis system in Vermont for designated agencies, but you can't be anywhere in Vermont and call one number. This would allow that option for people who don't know about the crisis centers at the designated agencies. So we needed to build it in Vermont. We didn't have the ability to answer the phone a few years ago. So we had a 0% in-state call response to that number. And when you call that number, even though it's called the National Suicide Prevention Lifeline, it says, we're directing you to your nearest crisis center. So to Vermonters, they were being kicked to New Hampshire, sometimes Kentucky, to receive that service. And we wanted in Vermont for many reasons. One, to show that we really value supporting Vermonters who are suicidal. Two, because then you can refer to services within Vermont if people want that. So we had 2 crisis centers come on board in the past couple of years, NCSS and KHS in Northeast Kingdom. We're now at an 85% in-state call response. Huge credit goes to those organizations for stepping up during a time of the staffing crisis, but it's been very successful. $440,000 is part of the budget that it takes to keep that running. So we actually had a quarter of it already paid for the mental health block grant. So this is 3/4 of the budget of what it takes to run it as it stands today. I think you'll hear from folks that there's some concern that as it stands today won't be what it looks like when it becomes 988 and lots more people call the line. But the department was asked, and we asked of the agencies, what would it take to sustain? And so that's the budget that's in the governor's recommend at this time. We do have 245 Vermonters on average using the service. That number was from about last year. We are seeing the increase starting to happen already, maybe about 325 calling per month. I will pause. I know you have other folks to talk to, but I'm happy to answer any questions.
So we have a question, and then do you want to take the screen down? And then Senator Hooker has a question. Then we'll move to Terry LaValle, who's here as well.
Actually, I had 2. I think they'll be quick. The 245 calls that you get, are they unique individuals? Do you have a way of separating, do you separate that out? Or are they?
They're right now listed as calls,
Calls.
not separate individuals. Yeah.
Thank you. And secondly, on the elder outreach, can you just explain what that entails? I mean, you talked about isolation and people who may be prone to depression and stuff. How are you made aware of these? How would you be made aware of these individuals?
Yeah, so it's a service provided by the designated agencies, and referrals often come from other providers. So they'll get referrals from primary care. For example, if somebody goes in, and thankfully now they're often being asked, how are you feeling? Are you having any symptoms of depression? They do a depression screen. And so if somebody does endorse that, it would be the referral to say, okay, because a lot of times people say, oh no, I would talk to somebody, but I probably can't get there every week. And this kind of takes all of that out of the equation and says, they'll come to you. And so often those referrals come from those sources.
Thank you. Okay, other questions for Deputy Commissioner? Okay, so we'll move to Terry. Thank you for being with us.
Thank you for having me. Thank you, Senator Lyons, and to the State Health Committee for the Senate Health Committee for hearing us today. In the spirit of transparency, I always like to say I wear a lot of hats in Vermont around suicide awareness and prevention. I've worked for a designated agency for 17 and a half years. I actually helped onboard the National Lifeline, and I've answered those Lifeline calls when we were short-staffed as extra job duties. But today, that's not the hat that I'm wearing. I volunteer for the American Foundation for Suicide Prevention. I am a board member for the Vermont chapter, a trainer, a walk chair, and I've recently joined the Project 2025 group. That's a national group where AFSP's goal is to reduce suicide across the nation by 20% by 2025. I had the pleasure of just getting back from Houston, where we had our chapter leadership conference. And right before we went, Caitlin Quinn had sent out our state report. And it was a little bit soul crushing to see that over the last 3 years, there was a 20% increase in suicidality in Vermont. The 3-year average was 117 individuals. So that was about 1 individual in Vermont every 3 days. Now we're up to 141 at the end of 2021. 1 individual every 2.5 days. So when I was at the chapter leadership conference, I really seeked out the states and our state leaders through the American Foundation of Suicide Prevention that had more rural communities to figure out what they were doing different and why our rates are going up in Vermont when we saw a 3% drop nationally. And what I learned was not a surprise to me. Our systems are working independently and we need to come more together, and we are severely underfunded. So that's why we're here today asking for the funding to make these systems work together, and the director's position that I'll speak to in a minute. So how I began my work truly is I'm an attempt survivor. And because of the stigma in Vermont, I've just recently started sharing that, and probably in the last 2 years, even though I've been doing this work much longer. And I'm also a loss survivor. I lost my nephew 6.5 years ago to suicide. So this is, I speak from many, many different angles as a professional, as my volunteer work, and with that lived experience. So I understand how these systems work together. So I'm going to share my screen. Hopefully you can all see this. I want to give credit to the National Association for State Mental Health Program Directors. They developed this model and it really resonated with me because it puts it in, I'm a very visual learner, and it puts it in a visual way that we can understand what's really going on in Vermont and what the asks are. There's some programs in here that we—
Carrie, your slides are not up yet.
All right, let's see.
Yeah, and we have your slides on now, have come up onto our webpage. So we have them here. See if you can get them up on the screen, and if you can't, we'll use ours.
Can you see this now?
We can see, no.
No.
You started screen sharing, but we can't see the slides.
Oh, let me try one more time.
Okay, but we do have them on our iPads and computers. So we see a cute little picture.
Good. It appears I can't share with everyone, so I'll just trust that you can see it, and I'll pull it up so I can see it myself.
We can, and you just tell us to.
Good. So I want to just start with the statewide director's position that's in our ask. In the budget, there was the request of 125,000. And we would like to up that to 125. As Allison said, she's listed as our statewide director, but we need a person. We need a person to pull all of the grassroots efforts that are already currently happening together to bring the full circle of the continuum of care to the state of Vermont. So as we go down the prevention funding line, the 988 funding, I love that 988 is being compared to 911, but honestly, the services are very, very different. With 911, you call and you get fire, police, or medical respondents, and you get dispatched to that. When you call 988, you get the service right there on the phone within 60 seconds of dialing that phone number. On July 15th, the 1-800-273 talk is going to become 988. We have no choice. Vibrant is projecting a 30% increase. And I have to tell you, being the one on the other end of that phone line through my professional work, it is a vital service. We are helping people every day. We are keeping individuals out of the emergency room, which is putting a burden on our physical health providers. And we are wrapping services with follow-up care, safety planning, assessments, all evidence-based practice tools that our Lifeline responders are trained to use to give the person the support they need within 60 seconds. So although I so appreciate all the work that our 911 staff does, 988 is very, very different than what 911 does. It gives you an immediate response to the mental health crisis. And the Lifeline has been advertised as a suicide hotline. As we move into 988, it is going to be classified as a mental health hotline. So we have to do more training with our staff around other mental health issues, substance abuse issues, and things of those natures. So 988, we asked, the recommendation was a $440,000 increase. And as Allison shared, that is just to sustain the lifelines. We are asking for an adjustment of $910,000 in addition to the $440,000 for $1.35 million for sustainability. This service is not going away, and it is so important that when our Vermonters call this lifeline, they're getting a Vermonter on the other end, a well-trained crisis clinician that can help them through their mental health crisis within 60 seconds. We do rely on our 911 partners currently for emergency rescue if somebody's at imminent risk. However, with the mobile crisis units that are in the proposals, we're hoping to lessen the burden on our 911 systems and create our own emergency crisis through 988. And I won't get into crisis mobile because I know that has been in other testimony and other asks. So the Vermont Suicide Prevention Center and the Zero Suicide Funding. We need a well-trained workforce. It's been a pleasure working with the Center for Health and Learning, being part of the Vermont Suicide Prevention Coalition. I've had firsthand experience on the impact that the Zero Suicide Funding has had, not only in our local designated agency, for our staff, for our call responders, but also our clinicians partnering with our primary care partners and giving them the evidence-based trainings, the tools they need to do the job, such as the Columbia Suicide Rating Scale, which assess suicidality, CAMPS Care, the Collaborative Assessment and Management of Suicidality, the treatment for suicide, looking at the drivers, not just the suicide itself, teaching people coping and resilience around that. So we had asked for $260,000 for the Zero Suicide Expansion Program. We're asking for an adjustment of $940,000 in addition to the $260,000 for a total of $1.2 million. We need to expand our zero suicide efforts to the designated agencies that aren't on board, but also to our primary care and our emergency healthcare providers. They see people the same as designated agencies, and oftentimes we don't, as designated agencies, people come in that die by suicide. They stop at their emergency room. They stop at their primary healthcare partner. We need to connect the dots in the continuum of care of systems. I already touched on the statewide director's position, and I just want to speak to the elder care clinician program and the vet to vet, two of our highest vulnerable populations in Vermont. We have a very high aging populations, and our veterans programs are underserved. So the ask of $100,000 to expand these programs would again bring services to where the people are at. Have them have home visits, have clinicians come out and see them, connect them to designated agencies, private therapists, whatever they need to stay mentally healthy. So in my little graph that I created for Vermont, the person in crisis, as we move up the system of care, it gets more expensive for Vermont. When we have people in hospitals, we're dispatching 911, we're not giving them that immediate response they need. It's more of a burden on our physical healthcare system and our first responder system. So we want to start putting the systems in place to move down the continuum of care, where the person in crisis can make a call to 988 or their local designated agency or SSA crisis number and get that safety planning, get that immediate assessment to say, we can get you through the moment right now, and then we're going to coordinate services for you in the future to keep you from having to enter the hospital or having to enter more restrictive healthcare providers. So if a person in crisis can have that hope, that warm connection to that person, and are brave enough to call those numbers and get that person to listen actively about what their struggles and their crisis are, 97% of our callers in the Lifeline never end up in the emergency room. They never end up in a psychiatric unit. They never end up going to most restrictive measures because we're able to assess, safety plan, and then do the follow-up care coordination to connect them to the services they need. As you all know, it's very, very tough right now, not just in Vermont, but nationally, to get a therapist, to get connected with a designated agency. So we do also, as in this, support the increase for the designated agencies, as well as in connection with the Zero Suicide, that is training the staff at the designated agencies to provide the supports around suicidality. So I know that you're running a little bit behind today, and I don't want to take up too much time, but I just wanted you to have the vision of how our grassroots efforts are already working together. We need to pull everything together. That's why that director's position is vital in the state of Vermont. Somebody that can work with 911, can work with our physical health providers, mental health, Center for Health and Learning, Vermont Suicide Prevention Center, and the coalition. All of these asks work together. Any area that is underfunded, education, that immediate crisis response, the mobile crisis unit, the designated agency, will do a disservice to the other areas. We need to fund suicide awareness and prevention. We need to use evidence-based practices, and we need to give our clinicians, our designated agencies, our physical health care partners, the tools they need to do their job and feel confident in treating suicidality. It's scary. People aren't comfortable talking about it. The stigma's high. We need to do better for Vermonters. And again, as I saw Caitlin Quinn's report as I was headed to the conference and saw a 20% increase in 2021, we're just at the tip of the iceberg of the post-traumatic stress of the pandemic. Our healthcare providers haven't even had a chance to process what has happened. What's going to happen when our healthcare providers start going into crisis? We need to make sure that everybody is well supported across Vermont.
Thank you. This is very helpful. And I think what we're going to do, because of our time today, we do have at least one bill we want to get to for markup and possible vote. I'm going to ask Katie McClinn to go through there's a proposal that the committee has that we had S69 here in committee. And then I was interested in acting on the bill, but it looked like a better option to wait until we got to budget time. And so now we're looking at something that there is money in the governor's budget. It did come to us from the House, and the language that we have in front of us that Katie has put together, Ledge Council McClinn has put together. I'm thinking it does include the additional funds, I think, that Terry, you were talking about. So what we're going to do, I think, right now, Katie, I'm going to ask you to walk us through this proposal amendment. And then what we will do, because it's an S bill, there's no place for an S bill in this world right now, but there is a place for the topic to move into the appropriations process. So as we're looking at our appropriations tomorrow and then next week, we'll put this one also into the topics of discussion. But I think the real issue for us is how much money can we invest in addition to what is currently being asked within the budget itself. And a lot of that decision making happens down the hall, not here. So it's the policy piece that we're going to look at with Katie right now. And then we're going to move on to Jen in about 10, 15 minutes. So that's where we are. Katie, thank you for being here.
You're welcome. Good morning.
Thank you, everyone. Please don't go away. As we go through this, there will be some questions, so appreciate your time. Okay.
Okay. Would you like me to pull the language up on the screen, or do you prefer just to use your device?
We all have it right here, so
Okay.
as long as we're on the same page, we'll go ahead.
Okay. So just to sort of ground you where we are, this is based on draft notes that were provided, I believe, by Terry. And it uses S69 loosely as a base. There are some sections that were pulled from S69, but there are also new sections. And I've tried to use the reader headings to sort of group like sections together. So the first section, you'll also notice I haven't used numerical section numbers because I wasn't sure what vehicle this would end up in. Just to give a little bit of flexibility. So first in section A, we have the appropriation for the National Suicide Prevention Lifeline. In fiscal year 23, the General Assembly is to appropriate $1.35 million from the general fund to DMH for the purpose of providing funding an anticipated increase in the use of the state suicide prevention lifeline call centers. And then there's a new chapter being created in section B that is specific to suicide prevention. And there are two sections in it. The first creates a special fund, and the second creates a commission. So I'll just pause here and note that I know Terry had asked for a trust fund instead of a special fund on this piece for its permanency. I was running the idea by our fiscal folks and our financing attorney, and there were some concerns about that approach. So I reverted to the special fund, which is more often used in Vermont for this type of set aside. So there is created the 1988 Mental Health Crisis and Suicide Prevention Special Fund. A special fund is established and managed pursuant to the structure set out in statute, and it's administered by DMH. The special fund the special fund shall solely fund expenditures recommended by the commission that we'll look at in the next section. The special fund shall consist of appropriations from the general fund, grants and gifts for deposit in the special fund, interest, premiums, gains, or other earnings on the special fund, and monies from any other source that is deposited in or transferred to the special fund. Monies in the special fund shall not revert at the end of the state fiscal year, but shall remain available for the purpose of the special fund and subsequent state fiscal years. It shall not be subject to transfer to any other fund or to transfer, assignment or reassignment for any other use or purpose outside of those specified in this section, and it shall be continuously appropriated for the purpose of the special fund. And I will note that myself and the attorneys who focus on financing and tax issues do have some concerns, particularly about the language in subdivision 2 and 3 as it binds the hands of future legislatures, which, as you know, we're restricted from doing. So I'll just flag that for the committee's consideration.
Yeah, thank you for doing that, because I know appropriations will not support that language, just so we all know that.
Okay.
Which I should let you all know up front. This is not something that the Appropriations Committee supports. So that kind of fund use, but so we'll go ahead. Go ahead, Kate.
Okay.
Message.
Oops, was there a question?
No.
No,
This is
okay.
a message from
Great.
above.
So the next section creates the commission, and as you will remember from the section we just went over, creating the special fund, this commission makes recommendations on the expenditures from the special fund, and the language in the special fund says that the funds in the special funds can only be used for this commission's recommendations. So just so you understand kind of the connection between the commission and the special fund. Yeah. So first, we just have the creation language that we're creating the 988 Mental Health Crisis and Suicide Prevention Commission to oversee all state-funded suicide prevention operations and to make recommendations on expenditures from the 988 Mental Health Crisis and Suicide Prevention Special Fund. Then we have the membership of the commission. Honestly, I didn't have a whole lot of guidance on who should be the membership. Who should be a member of the commission. So what I did is I pulled the membership list from the working group on crises that this committee looked at earlier this session. It was the language underlying S-197. And you'll see that that whole section, the original S-197, has been added at the end of this draft. So the membership list is the same in both. So that might be something the committee wants to take a deeper dive on, who should be the members of this commission. In terms of powers and duties, the commission is to oversee all state-funded suicide prevention operations, including the Zero Suicide Program and Suicide Prevention Lifeline call centers. And also the group is to make recommendations on expenditures from the special fund. The group has the assistance of DMH and has to do an annual report, including its recommendations for expenditures from the special fund and also any other recommendations for legislative action. we have this as an ongoing group, so it would be in the green books. It doesn't have an end date, a termination date. And then we have reimbursement of expenses for 4 meetings annually. Next, changing subjects. This is the Zero Suicide Program expansion. So first we have the appropriation that in FY23, the appropriation is for 1.2 million from the general fund to DMH for the purpose of expanding Zero Suicide Program and other comprehensive suicide prevention initiatives to engage a statewide coalition with broad public and private sector representation and building coalition partner capacity to assist in suicide prevention planning and implementation. And the evaluation that includes first, expanding the Zero Suicide Program through workforce development and technical assistance to 10 designated agencies, 2 SSAs, and preferred providers, including expansion to primary care practices. Second, build school-based pathways to care through the You Matter for Schools program. Third, offer access to ongoing gatekeeper training throughout all communities with a focus on cultural competencies. 4, support public education and information to reduce stigma associated with help seeking and to improve awareness and access to suicide prevention support and services. And lastly, support coordinate or offer any combination thereof comprehensive suicide prevention and postvention training throughout the state. And I just would flag this term postvention doesn't turn up often or at all in our statutes. So you might want to consider a definition if you move forward with this set of language. Next, in section D, this is creating the director position. So I've pulled apart, this was sort of drafted to have an appropriation. I've pulled apart the appropriation and the actual establishment of the position because the director position will be ongoing in law and the appropriation will be a one-time appropriation for the coming fiscal year. So we have a language that establishes a permanent full-time director of suicide prevention within DMH to coordinate statewide suicide prevention efforts across state government and in collaboration with community partners, mental health and healthcare providers, crisis providers, and other organizations regularly interfacing with individuals at risk of death by suicide. And the director shall work with stakeholders such as the Vermont Suicide Prevention Coalition to oversee the development and implementation of a comprehensive state plan for suicide prevention and promote positive youth development for lifelong mental health through school and health education in coordination with AOE. And then in subsection C, we have a report back annually. The director is to submit a written report to the committees of jurisdiction on the development and implementation of the comprehensive state plan for suicide prevention required pursuant to the previous subsection. And then in section E is the appropriation. In fiscal year 23, 125,000 is appropriated from the general fund to DMH to establish the position. And then section F, this language was originally in the original S69 with a different appropriation. So in fiscal year 23, the General Assembly appropriates 100,000. I think it was previously 50,000 from the general fund to Dale for the purpose of expanding elder care clinician program or the vet-to-vet visitor program or both. And then lastly, we have section G, the Coordinated Mental Health Crisis Response Working Group. I know you're in a crunch for time, so instead of going through this, I'll just say this is the language from the original S197 before the focus of that changed to look at mental health in school settings. And I'm happy to go through it in more detail another time when you have a little bit more time to look at it.
That's okay. We're good. Yeah. Okay. So essentially what this does is it has established a fund and then a commission that can make recommendations on the use of the fund. It establishes a director and then it establishes another group that can help define the system and put the system in place. So there's a lot of work embedded in the bill. And the money that's here is, will, as we go through what's in the budget tomorrow, we'll be able to see differences between what's here and what is in that budget as it came to us from the House. Okay. So what I'm going to ask of you folks, of Deputy Commissioner Crump and of Terry LaValle and of Joellen and Nicole, if you would please review the language that Katie has just put forward, in particular the membership on the commissions, that how does, and then what the commission will be doing and what the director will be doing, and to offer, to make sure that we're getting it right in many ways. And we'll go through the language individually and then come back to this going forward. So thank you all for your work on this. I know that little bill has been sitting on our wall, and we didn't want it to be forgotten. So we're pleased that maybe we can do something with this. We'll see. Okay. So thank you.
Thank you for squeezing us in. Appreciate it.
Thank you very much.
Thank
We
you.
know there's a crisis out there, and whatever we can do to quell it will be so critical.
Thank you.
So Jen, we've got 10 minutes, and I leave a couple minutes early, so I got it. We have 10 minutes. So I'm thinking that if we could just look at one of the bills that we have, and maybe act on, and we will have time on Friday to go through the others. So we have page 655, 153, and 266, which are near or complete. I think 655.
That's only have to go to 2 committees after this. So that might be, if you're looking at timing, that might be a good one to.
Yeah, that's what I was thinking. I mean, each of the bills that we're gonna be taking up, with little exception, are gonna have to go somewhere else. So, you know, I think we need to start. So 655?
Yes.
Okay.
So I'm back with you, Jennifer Carvey from the Office of Legislative Counsel. H655 is an act relating to telehealth licensure and registration and to provisional licensure for professions regulated by the Office of Professional Regulation. We've gone through it a few times. The general overview, section 1 creates telehealth licensure and registration process for people who are not healthcare professionals who are not otherwise licensed, certified, or registered to provide services in Vermont. So if they're a Vermont, lump them as licensees. If they have a Vermont license, they don't need to get this specific telehealth license. Doing telehealth is already included in their Vermont license. But for anyone who is licensed somewhere else in the US and wants to be able to provide either services to a limited number of patients, not more than 10 for a limited period of time, 120 days over a 120 days, and not again for another 3-year period, they would get the telehealth registration. If they want to provide more telehealth services in Vermont to up to 20 different patients over a 2-year period, they can get a telehealth license, and that one is renewable. And then if they want to have a big Vermont telehealth presence, they would need to get a regular full Vermont license. There are fees in it that the Finance Committee will look at, and there is an appropriation for setting up the system. And then section 2 of the bill is broader than just healthcare professions. This is the one that would allow OPR to issue a 90-day provisional license to someone who has done their application and they're waiting either for verification of their licensure from another jurisdiction, but it's taking a while, or they're waiting on a background check and that's taking a while, or they're an active duty member of the U.S. Armed Forces assigned to Vermont, or that person's spouse, and they'd be able to start working as soon as they got here, or sooner than waiting for the full licensure process. So that is basically what is in that bill. And you've heard from Lauren Hibbert, you heard from Jessup Barnard, maybe somebody else, Lori Houghton, Rebecca Copans, Rebecca Cross.
That's right. I'm just, is there are there any changes that the committee would like to recommend to the bill at this time?
Right, we had not requested any changes, so right now we're still just looking at its passed by House.
Is there discussion?
And I move.
Senator, welcome.
As presented.
Okay, so the motion has been made to approve H 655 as passed by the House to the full Senate. Discussion, comments, questions?
Just for purposes of the form draft number, so it's, it would be draft number because it's.
Right, it's just as passed by House.
Okay. Discussion? It's been a whirlwind day. Another
easy one.
Okay, Mr. Clerk, Senator Clerk, please call it.
All right, for each 655, myself, yes. Senator Booker,
Yes.
Senator Cummings,
Yes.
Senator Hardy,
Yes.
Senator Lyons.
Yes.
Vote of 5-0-0.
Okay, this is good. This will go to finance. It's got the little fees in it for us.
We'll knock it out in 30 seconds.
And it's not a difficult bill to report, so I'm happy to report it, but if there's someone else who would like to report it, that would be fine.
I think you've done all the other ones, right?
Yeah, this is kind of similar. Okay, all right, we'll do that. Do I need a clean copy? You just, I have to carry something up, so I'll carry whatever you have. All right, thank you for that. And we've got 7 minutes. Do we want to attempt
I've got to go. Otherwise, I don't.
266? Okay. 266 is the hearing aid bill.
Okay. I have an amendment on that one.
Is that, what's 153? Does that?
153 does not have an amendment. That one will go, I believe, to appropriations. That's the Medicaid reimbursement rates for
Yeah.
those providers.
Yeah, want to look at that one?
Yeah.
Okay, let's look at that one because that doesn't have the amendment. We'll look at the other one on Friday.
Which one? I'm sorry. This is H153.
153. Good, yeah, we have 3 bills up to this morning.
Oh. I might have an amendment that I want to do on this one, so
There you go.
I don't have it ready yet.
Well, let's hold off then, because we'll look at it. Would you have it by Friday?
I can, yeah.
Okay, let's do that. Let's hold that one off. And then 266, well, we have time, we have them scheduled on Friday already, do we not, Aaron? We haven't changed that yet. Yeah, so we'll do 153 and 266 on Friday, and that will make us all feel a little more comfortable. We've had a very difficult one.
Right, and the 266 amendment, I think, is posted, and so that way, if anybody has comments on it, they can
Yeah, okay.
let us know.
Thank you.
Thank you.
Thank you. Thank you, everyone.